Hello, my name is Professor Manu Shankahari. I'm a critical care physician based in London, United Kingdom. I'm going to give you a brief overview of the new domain in REMAP-CAP, known as the cysteamine domain. Briefly, cysteamine is an endogenous molecule. It has got anti-inflammatory properties because it reduces interleukin 6. It has got antimicrobial properties, and the antiviral effects are mediated through an increase in type 1 and type 3 interferons, and it also potentiates antibiotics, and therefore it's got an antibacterial effect. Because of the antiviral and antibacterial effect, we are considering this intervention for REMAP-CAP. As a drug, cysteamine has been around for more than 20 years, commonly used in patients with cystic fibrosis, and there is evidence in that space that it reduces the inflammatory response and severity of exacerbation in cystic fibrosis. So let's look at the intervention in the context of the REMAP-CAP trial. Within the cysteamine domain, we have two interventions, no cysteamine and cysteamine. And the patients that will be enrolled into the cysteamine domain comes from both the PISOP, which is the pandemic infection suspected or proven, and PINSNP, which is the pandemic infection neither suspected nor proven stratum. It's available in patients in the severe state, i.e. requiring organ dysfunction in an intensive care unit setting. Eligibility to the domain, anyone who is eligible for the overall REMAP-CAP platform is eligible, potentially eligible for this domain, and that participant could be a PISOP or a PINSNP participant. A PISOP participant is patients with COVID-19 infection suspected by the treating clinician or has been confirmed by microbiological testing, and the PINSNP, which is community-acquired pneumonia of bacterial or viral etiology. What are the exclusions that are specific for the cysteamine domain? The platform level exclusion of more than 48 hours has elapsed since admission to ICU is retained in this domain. The other exclusions are known severe liver disease, known hypersensitivity to cysteamine, or there is an intention to commence or continue, or the patient has been randomized in another trial of cysteamine by any route, or intravenous N-acetylcysteine and or carbocysteine by any route. If you are giving N-acetylcysteine as part of prophylaxis for contrast, that is not a contraindication or an exclusion criteria for this domain. And the other exclusion criteria are the same as for the rest of the REMAP-CAP platform, which is treating clinician believes that the participation is not in the best interest of the patient, or the patients who are known or suspected to be pregnant or breastfeeding. There is one intervention-specific exclusion criteria that I need to highlight, which is known hypersensitivity to N-acetylcysteine or NAC, penicillamine, or aminophistine. The reason why these three drugs are specifically highlighted as an exclusion criteria is because cysteamine shares some of the structural similarities with these drugs. Let's look at the intervention in a bit more detail. The no cysteamine intervention, patients are not to receive any cysteamine up to day 28 or until hospital discharge. After randomization, cysteamine can only be administered for an established clinical indication such as cystic fibrosis. There is no placebo, it's an open label domain. The cysteamine intervention, cysteamine is administered at a dose of 5 milligram per kilogram, estimated or measured body weight. The maximum administered dose at any one point in time does not exceed 500 milligram. The dose needs to be diluted in 50 to 100 mils of 0.9% saline and administered as an intravenous infusion over 10 minutes. It can be administered via a central or a peripheral venous catheter. Cysteamine has to be administered 3 times daily until study day 10 or critical care discharge, whichever occurs first. The drug comes in ampules. Let's look at the cysteamine intervention for patients who are discharged before 10 days. If the patient is discharged before 10 days, the discontinuation of cysteamine is not considered a protocol deviation. If the patient is readmitted to ICU before day 10, then cysteamine need not be recommenced. If you omit 3 or more consecutive doses of cysteamine, it's considered as a protocol deviation. Coming on to the primary endpoint. The primary endpoint for this domain will be the primary outcome specified in the version of the REMAP-CAP core protocol that is operative at the time of each adaptive analysis. The 90-day mortality is the currently proposed primary outcome. The reason why the primary endpoint is described like this is because this drug is going to be trialed in both the pandemic and non-pandemic domain, and we are finalizing the analysis plan for the intervention. Domain-specific adverse events. One of the possible adverse events is an anaphylactoid reaction, and this will be kind of manifested as either urticaria, pruritus, facial flushing, wheezing, dyspnea, and or hypotension. This is one of the reasons why we are asking the trial sites to dilute the drug in 50 to 100 mils and administer it slowly over 10 minutes. Another important domain-specific adverse event is hypocalcemia. And the way we define it for the purpose of recording is that it's symptomatic or requires treatment or both. You don't need to measure specifically for this domain if the patient is asymptomatic. If you're treating or the patient is symptomatic, then record it as a domain-specific adverse event. With long-term therapy with cysteamine, there has been reports of neutropenia. Therefore, it is recorded as a domain-specific adverse event, and the definition is total neutrophil count less than 1. And I'll leave you with the summary slide and happy to take any questions.